we'll have some a few minutes for questions. So please type your questions or raise your hands. So we have a couple already. One says, it was to a previous slide, the bivariate model, the diagnostic test accuracy meta-analysis model. And this question says if this is analogous to the random effects meta-analysis. So
I'm not particularly sure about the question. So the bivariate model is a random effects meta-analysis model, and you can think about it as being two random effects meta-analysis models, one for sensitivity and one for specificity. And through that covariance parameter, that's what allows us to perform the joint synthesis to account for the correlation between sensitivity and specificity across studies. So I don't know if that answers that question.
Yeah. So, okay, excellent. So this clarified this question. The next question says, thanks for the great presentation. Is it possible to pull the data without identifying true positive, false positive, false negative, and true negative? In another word, sometimes studies do not report those, but only sensitivity and specificity, yes. So if you can comment on that.
And so is this where, sorry, I didn't quite get that. Are you saying that only sensitivity and specificity, only one of the two is available? So there's some studies that report only on sensitivity.
It says in the question only sensitivity, but if we can, it says, yeah. So the question is about sensitivity and specificity. So when we don't have the 2x2 table, but we have sensitivity and specificity.
All right. Okay. So you only have the actual number. So you can't use this method because we need the 2x2 data to be able to use any of these methods. And if you only have the actual sensitivity and specificity, it's a bit like with interventions where you've just got, say, your relative risk and you don't actually have the 2x2 data, and then but because you've got those estimates and their standard errors or the confidence interval, then you do an inverse variance weighted meta-analysis, something like that. But we tend not to do that because, again, if you've just got the sensitivity and the specificity, you still need to jointly synthesize the two and not just do a meta-analysis of sensitivity on its own and one of specificity on its own. And I haven't actually seen any examples where they've done a modification of a model to be able to pull that. So that may be, so you can't use any of the methods I've presented today.
Great. So the other question says, thank you, Professor Takwangi, for the great presentation. What is the minimum number of studies needed to be able to perform a compare meta-analysis of DTA?
Oh, excellent question. That's always the question. It's a bit like how long is this piece of string, really? And we know that fitting these models is not trivial because of the number of parameters that we have to estimate. Now, I've done a simulation study in the context of just the meta-analysis of a single test and shown that you can simplify these hierarchical models by removing certain parameters. For example, if it's the bivariate model, the first simplification is to remove the covariance between the sensitivity and specificity, that parameter from the model. So in effect, reducing the bivariate model to two univariate random effects logistic regression models. And based on what I found from that, and also an empirical evaluation that I've done, which sad to say I haven't published yet, but is in my thesis, is again, the answer there is that that's a reasonable simplification to do when it's appropriate to do so. And also, if you observe that there is little variation in either sensitivity or specificity, you can simplify the models by taking out those variance parameters from the model. So my answer is that you can simplify the models, but we don't have a set number to say if you've got 4 or 5 studies, this is the limit. But it's just something that you have to approach and think carefully about and see what's the best way of simplifying the model based on the observed data.
Perfect. So the next question says by Philip, in DTA meta-analysis, multivariate approaches are recommended. Why the connection between DTA and NMA and treatment NMA is difficult? Because the multivariate factor in DTA meta-analysis?
So there's the multivariate factor is one, and the other thing too is to do with the type of data, and that's why I spent a bit of time looking at those different study designs, because we've got multiple tests on the same participants, and we know that there's likely to be correlation between the test results of patients. And so that's an additional factor that we need to take into account. The other thing too is this issue of multiple thresholds. Again, like only one of the NMA models, the model by Owen, that allows you to take that into account. So all of these issues make NMA of DTA studies more complicated because of these different study designs and also differences in thresholds. And then there's the bivariate nature as well.
Thank you. So we're running out of time, so I'll ask maybe another 1 or 2 questions. So the next says, if heterogeneity is high, this could be considered a high level of uncertainty, but is there recommended heterogeneity?
No, there isn't. And so I mentioned before about looking at the DTA reviews and the Cochrane DTA reviews, and some of the reviews haven't done a meta-analysis either because there were few studies or because of clinical heterogeneity. So there'll be instances where it's not appropriate to perform a meta-analysis because there's just a lot of differences, clinical differences between studies, and so obtaining a pooled result doesn't make any sense. Even if you do the meta-analysis, people will not believe the results. So that's one thing. And then the other aspect is using this random effects models that allow us to incorporate this between study variation. So that's, if you decide that a meta-analysis is appropriate, then use a model that will allow you to incorporate random effects.
Thank you. And the last question says, how reliable is the average sensitivity specificity estimates when you conduct an indirect comparison of DTA? It could happen the sensitivity and specificity of that same test using the same cutoff can vary depending on the patient's cohorts, for instance. So, yeah.
Yeah, that's possible, and that's why we say that if you do an indirect comparison, if you've got comparative studies, even if they're few and you can do a meta-analysis, it's still good practice to report on the comparative studies and to see whether the results are in the same direction, and also to, when you interpret results from an indirect comparison, to add a caveat, because there's still that potential for bias due to confounding. So we say that in the Cochrane DTA editorial team, and also in that Jacqueline Epi paper that I showed earlier. It's really important that for indirect comparisons, we do make that quite clear. And of course, again, always interpret results within the context of what you're doing, because you need to take into account the patient population. So if the studies are all from secondary care, but interest is in how the test performs in primary care, then again, you need to reflect that in how you make sense of the results from the comparison.